Hi everyone, a very warm welcome to tonight's WM UK webinar on demystifying the diagnostic process. It's lovely to see that so many of you have joined us. Just some quick housekeeping before we start, if that's okay. Just to let you all know, the session is being recorded and will eventually be uploaded onto YouTube. So we'll send a link once that has been done. Just a polite reminder, if you can all stay on mute for us, that would be brilliant. And finally, if you do have any questions, you're welcome to put them in the chat box, but we will go through any questions at the end. And if there's any questions that we don't get round to answering, we'll of course get in touch with you after the webinar to help you with that. And yeah, just to kick things off, I'd like to introduce you to Chrissie Kirby. She is a wonderful haematology nurse specialist who has loads of knowledge and is also a great friend of WMUK as well. So over to you, Chrissie.
Lovely. Thank you for that introduction. So what I'm going to do is I'm just going to put you to the side of my screen, so I might not be able to see you yet. I'm just going to check that the screen works. So today, welcome everybody, and thanks for joining this evening. Um, I am Chrissie, and I'm a haematology specialist nurse, and I have been working in haematology for about 13 years now. So I've got a varied amount of experience in this area, and I've done a lot of work with WM UK and with WM patients as well as lymphoma patient in general. So today's session is all about demystifying the diagnostic process, and I'm going to talk a lot about diagnostics and testing. So here's just a little bit about me. Hopefully you can see that. Just to mention as well, I work for Lymphoma Action as one of their trustees as well. So just to kind of cover what we're going to be talking about tonight, hopefully you can see that screen. Rachel, can you just confirm it's showing?
Yes.
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 Thanks, everyone. So, what we'll cover in this session then is we will demystify the diagnostic process and answer the most common questions asked at diagnosis. So, things like what is WM? Oh, can you hear me? I think I've been muted.
Yes.
Okay. If you can all put yourself on mute, that would be great, just because it kind of echoes. Is that all right? Thank you so much. So understanding WM, symptoms of WM, and
I can't hear it.
can you hear me now?
I can hear you. Could everyone else hear Chrissie?
Rachel, I keep on getting muted. Someone keeps on muting me.
Right.
Yes, I can.
If everyone else can mute themselves other than Rachel, you should be muted.
I'm muted, am I?
You just see. See if that helps, Chrissie.
Yeah. Okay. Can you hear me, Rachel? Yeah. Thank you. Okay. So just going back with what we'll cover then. So understanding WM, symptoms of WM, and then the testing process. So what bloods we do, the bone marrow process, and gene mutations and scans. And then also I'll cover related conditions as well. So, what is WM? So, WM is a rare type of blood cancer and is a type of non-Hodgkin's lymphoma. Now, you may hear WM being referred to as a type of LPL, and in fact, it is the most common subtype of LPL, but it's not the same thing. It does differ, and that's because WM has a detectable level of an IgM antibody called paraprotein that is found in the blood, and that is not found in other types of LPL. Other antibodies are found instead. Now, if you have presence in WM of this paraprotein, it can make the blood thicker. And this is a condition called hyperviscosity, so where the blood is too thick. And this can cause very unique symptoms, which is seen in WM specifically. Now, unfortunately, at the moment, WM is not curable, but is very much treatable. And often, treatment doesn't need to be started straight away. We have time to treat it and to monitor symptoms. So most patients would start when they're diagnosed, would be entered into what we call active monitoring. So how is WM diagnosed then? So most of the time, when people receive a diagnosis of WM, it's usually through a incidental finding where they're being investigated for another condition, or they've got a set of symptoms that they've gone to their GP and it's been uncovered that they have got WM. Now we know from this condition, as it's a type of lymphoma, that it is slow growing and can develop over time. Some people may have no symptoms at all when they're first diagnosed, so that's not uncommon. And that can make it quite shocking when you're first diagnosed, for the pure reason that it may be completely unexpected, or that you might be going for other testings, for other things. So I've had many patients over the years that might have been going for surgery or something, or they might have been going for their well woman test or their well men's test, and something actually popped up through the blood test there, which led to their diagnosis. What we do know with WM is that it's diagnosed through blood tests and a bone marrow test, and that's how we find out that people have got this diagnosis. So if we take you back to what our blood cells should be doing and the blood cell production, our bone marrow creates red blood cells, white blood cells, and then platelets. The white blood cells then go into T cells and B cells, and the B cells that we need in our body will then turn into plasma cells, which create these antibodies. And now antibodies are a part of our blood system. We need those to help fight infections. So that is a normal process. So as you can see, then, when understanding a WM diagnosis, WM with the B cells, which is a type of white blood cells. So back on that picture, you see the white blood cells are broken into T cells and B cells. Well, in this WM, it abnormally creates more of these B cells and multiplies uncontrollably. These cells will then crowd the healthy cells, preventing them to function properly, leading to symptoms. So going back to that picture, if you can see, if you have too many of these B cells, it will block all of the red cells and white cells and platelets and allow them not to work sufficiently. So that's how people can then become anemic, or they can have a low platelet count and have symptoms of bleeding, because our bone marrow can't function properly because there's this overpopulation of the B cells. Now, B cells are part of the immune system and they're developed in the bone marrow.
You've got that.
Bone marrow and become plasma cells, which produce these antibodies that help to fight infections, as I said. So healthy B cells create immunoglobulins, and our healthy B cells create IgM, IgG, IgA, IgE, and IgD. So all of these different immunoglobulins are used and help us, our bodies, fight infections. So when you look at the blood cell production when it comes to WM then, which differs, is, as you can see with the white blood cell, it creates the T cell and then the B cell, and then the B cell is overpopulating and it creates these abnormal IgM paraproteins. So that affects the IgM part. So all of these are overpopulating and you're not getting cell death, you're just getting an overcrowded population of these paraproteins. So what does that mean then for people with WM, or how does that affect it? So we know that in WM, if you have large quantities of these paraproteins or IgM, it actually means that it can cause symptoms like headaches, shortness of breath, dizziness, confusion, and also this numbness and tingling in your hands and feet can also be common because it is creating this thickness in the blood. Most common symptoms that we can also see with WM is things like fatigue, repeated infections, bruising and bleeding, along with all of these other things that are listed here. So we've already kind of touched on poor concentration, blurred vision. I've had quite a few patients that have come through with issues with their eyesight over time, and it's because their paraprotein is getting higher and higher. Swollen lymph nodes, we see that. Fevers, lumps, bruising and bleeding related normally to the platelets being low, repeated infections because we know that it's affecting our B cells which help to fight infections, unexplained weight loss, fatigue, all of these things can happen. So in terms of symptoms, symptoms do differ from person to person. So not every patient experiences the same thing with WM. So some will not experience any symptoms at all. Like I say, at diagnosis, it can be a lot of the time quite a shock because there was almost there were no signs or symptoms of that even to kind of get to grips with. Some will experience a few symptoms which may need to be monitored, and some may need further tests or even to start treatment because of their symptoms. And we know that there are symptoms that are directly related to the WM, which I've already spoke about, but also there are some that may not be related and that some are very difficult to manage. Things like fatigue can be often quite difficult to manage, as a lot of you may already know. So what can you do about your symptoms? And this is really important when you're first diagnosed to, I find is quite helpful, is to make sure that you discuss your symptoms at each clinic appointment and often make like a symptom diary or like track your symptoms. And that's to kind of give a log and it'd be helpful to the clinician who's looking after you to kind of see the patterns or changes that are happening with you. So, like I say, sometimes it can be quite subtle changes, but it gives us an indication. And a lot of the times, although we're looking at blood test results to guide treatment, sometimes it is the symptoms that are triggering treatment alone if people are struggling along with a high paraprotein level. So moving on to blood tests then, and the relevance of blood test is when the GP, so this is at the diagnosis point or when it's being suspected, because we know it can take a while to get a diagnosis of WM because of the level of expertise that it needs and genetic testing for confirmation and bone marrows, but I'll talk about that a bit more in a minute. But in terms of blood tests, what are we looking for? So we're trying to measure the antibody levels, check for any abnormal proteins, check if any blood counts are low. So like I said earlier, we check the hemoglobin level, so the red blood cell production. Are there low red blood cells or are there low platelets? Because we know that can happen when the WM is kind of filling up that bone marrow. And checking for any infections as well that you might be experiencing. And we can check that in the blood as well. Now, you cannot diagnose WM simply with a blood test alone, so it does require further investigation with a bone marrow biopsy. So when you've been diagnosed with WM, doctors will regularly monitor your symptoms, and blood samples are part of that. And blood samples will help us to kind of keep track of how the WM is doing or progressing. Often we use it to guide us how treatment is going as well, because you can then see the decrease in the paraprotein level. It is important to note, though, that normal results may vary person to person.
I can make the effort, yeah.
It's important not to compare to one another. as treatment is not just based on bloods alone. And that's important to note because a lot of the time I think you may see that there's some people that might have a higher paraprotein who might not be starting treatment yet, and others who might have a little bit of a lower paraprotein level, but they need treatment because of the symptoms they're experiencing. So there are different reasons for starting treatment, and that's important to note. So in terms of what are the blood tests or the main blood tests we do and what do they mean? So one of our main blood tests that we check for is a full blood count, and that measures the red blood cells, the white blood cells, and the platelets. And obviously, as we kind of stated already, we know that in WM you may have low blood cell count. So that would be able to give us an indication if you are anemic or if you have low platelets, that would show up in this, as well as your white cell count and if that's being affected. We also can look at the serum immunoglobulin. So as I've said already previously, it's normal and our B cells create these immunoglobulins. So everybody has these immunoglobulins and we need to check these levels, but we know that it's the IgM that is raised in WM. So we'd be measuring the antibody levels and looking specifically at the IgM. Serum-free light chains is a more in-depth level of looking, and it also then reveals the paraprotein. So WM produces this abnormal IgM, and these immunoglobulins are made up of chains of proteins, and they split into two groups. Called the kappa and the lambda. You don't have to remember all of this, but it's just a bit more of a detailed explanation. Now, what's important about the kappa and the lambda is normally you have a higher one of each. You either have more kappa or you have more lambda. Now, what we look at is when WM is progressing is we're looking at the ratio between them. So that is something that we can look at through the blood test. We also look at plasma viscosity. So this basically means how thick is the blood. High levels of IgM, as we've highlighted, can make the blood thicker and can cause this condition called hyperviscosity syndrome, which will require medical treatment if your blood is too thick and it's causing these symptoms of confusion, headaches, all of these things that can be quite dangerous if left. And then finally, we look at things like the beta-2 microglobulin, and that measures a protein specifically called beta-2 microglobulin, which suggests how severe the disease is if found in high levels. So it's another marker that we can use in the blood to kind of see the severity of the condition. So moving on to the bone marrow biopsy. So a bone marrow biopsy is needed to detect whether, to confirm a diagnosis of WM. So the bone marrow, as we've described already, is where our blood cells are made. And you can find the bone marrow in our big long bones, like our hip. Okay, so a bone marrow biopsy is a procedure where they take a small sample of your bone marrow, they take a bit of the liquid, which is known as the aspirate, and they also take a bit of the bone itself, a tiny bit, which is called the trephine, which they look under a microscope, and it goes for further genetic testing. And this is how we can get this diagnosis. So in terms of a bone marrow procedure, normally you're lying on the side. They put local anaesthetic into the back, and then they take it from the hip. They take the sample from there. The procedure normally takes about 20 to 30 minutes, and although local anaesthetic is used, it can be quite uncomfortable, and some people might need gas and air or other medication just to help that process along. But it is a test that is needed in WM to basically confirm a diagnosis. And then when the samples are sent away, they're looking at the genes. They're looking at many things, but one of the things we're looking at is gene mutations. Now, we know that most cases of WM involve a mutation specific to the MYD88 gene. Now, this gene normally acts as a messenger But when it's faulty, like in WM, it sends a false signal that causes the cells to grow and survive unnecessarily. So it's that mutation that is driving that. Now, this mutation not it's not hereditary. It is acquired. So it's not something that's just passed down necessarily. But it's a gene that is what's kind of causing or part of that process. We also know that 30% of WM patients also have a mutation in their CXCR4 gene, and this gene encourages the faulty cell growth and keeps these cells trapped in the bone marrow, which crowds the healthy cells. So a combination of both of those is really not helping, basically. And there are rarer type of gene mutations which can also influence how WM can behave, such as things like the WNK2, the NFKB2, and the CARD11, as well as the PTPN13. Like I say, these things are very academic, but it's just to note that WM normally has mutations, and it's the mutations that are driving these things, and it's the gene that's not allowing the cell death process, which we need. We need our cells to die, so when we can get new cells, and it's that overcrowding that causes the issue. It's the proliferation of those cells. Now, research currently is exploring how gene mutations influence the development of WM and its response to treatment. So the future hopefully is around targeted treatments that are going to target these genes specifically a bit more to, especially if you've got presence of certain rarer genes, whether there's treatments that can help turn this gene off, or the stimulation of overproliferation, so on overproduction. So that is where the research is going, in more targeted treatment, whereas we know that some of the standard chemotherapy style treatments very much kill both good and bad cells. So they're not necessarily targeting the WM specifically. So a lot of the treatment advancements are coming with targeting these specific genes, or seeing whether they can target these specific genes. And then we move on to CT scans. So CT scans cannot be used on its own to diagnose WM, but it can be helpful to see if the WM is affecting other parts of your body. So as I said at the beginning, WM is a type of lymphoma. So some people with WM have enlarged lymph nodes in their body that are causing some of the issues from these B cells, creating these pockets and growing these lumps almost of these B cells that cause issues if they are growing at a size or starting to interfere with the internal organs. So that's what a CT scan will show. It will show if there's lymph nodes, or how kind of affected other organs are in your body. Now, CT scans can take about 30 to 60 minutes. And once you are ready to be scanned, you'll lie down on a bed and then move slowly into the scanner. And then we get the results back from that. Sometimes it can take a couple of weeks to have a full report back, depending on what hospital and your radiology department. You may be asked to have a PET scan, which is a type of CT scan. It's a bit more specific, and a bit more intelligent in the way that it behaves. Is that what happens is that you're injected with this glucose tracer. It's harmless, that goes in. It's a radioactive tracer, and basically it picks up in your body areas that are working harder. And we know with lymphoma or lymph nodes that they are working really hard when they're enlarged. So they will scan, or they will highlight bright on the screen in places. Now, there are some places that will shine bright anyway, because things like our brain is working very hard, and our heart and our lungs. But it will highlight other areas which shouldn't light up. And depending on how present the node is, it will shine brighter, basically. The bigger it is, or the more of the problem it is. So it gives a bit more of a detailed scan. But like I say, it doesn't diagnose WM, so you don't need a CT scan necessarily. But if you presented with lymph nodes, or you had like an enlarged lymph node in your neck or your armpit or your groin, they may send you for further tests just so we can get a full picture. So in terms of things like related conditions, so because of the presence of this IgM paraprotein, we can see some of these conditions, related conditions, when you have WM. So these are not uncommon, and there is a specific booklet on related conditions. Now, some of these things may not affect everybody, but we do know that it does for some. So we've got hyperviscosity, which I've spoke about already, which is when the blood is too thick, and it can cause certain symptoms because of that. Cold agglutinin disease. So that's where the antibodies clump up the red blood cells, and it affects the body's temperature. It makes it drop. So it means that sometimes people, when it's cold, their hemoglobin levels are dropping further and they need transfusion. And when they need a blood transfusion, the blood has to be given warm as it goes in. Bing-Neal syndrome is quite rare, but I've seen it quite a few times, and that's when the abnormal cells that your body's producing can enter the spinal cord and can cause problems with your central nervous system. Peripheral neuropathy is one thing that I think a lot of people can experience with WM, and that is where it's affecting the nerve endings in your fingers, in your toes, and it's basically impairing the signal between the brain and the parts of the body. So we can see that when people have got high levels of paraprotein, often you can see that they start getting these symptoms of peripheral neuropathy. And it's one question that clinicians will keep on asking is, can you feel your fingers and toes? Have you got tingling, numbness, or pins and needles? Is one question that we often ask. And then also we've got cryoglobulinemia and amyloidosis as well. So there's various different related conditions. You would know if you've got a related condition at diagnosis. And like I said, if you want to know more about related conditions, there is a specific booklet on this. And then finally, I'm just going to highlight the active monitoring checklist. So for the majority of people that are diagnosed with WM, they don't need to start treatment straight away. And they go onto this program, which is called active monitoring. It was known before, and many of you may know it as, or heard of it being called as watch and wait. And it's basically the monitoring of the condition. So when we know that it doesn't need treatment straight away, we monitor the bloods and your symptoms, so we can then detect when we need to start treatment. And it's all about like surveillance, basically. But it can be a nerve-wracking time, and for a lot of people, it's difficult having or being diagnosed with a cancer and being told that it's not going to be treated, or that it doesn't require treatment at the present. So it's how to live well with WM, and know that there may be a time that you need treatment, or there might be a long period of time that you are just being monitored in clinic regularly. Most people will be monitored every 3 to 6 months. But that could extend slightly if your condition was stable and you had no issues. But this checklist is really important, and it's part of the new diagnosis booklet that hopefully you all have had. It's a pull-out version, but you can request to have the copy sent to you as well. And I'm using this in my practice, and it kind of really puts it back to you of what is important as part of your WM, or what do you know, and what support basically should be available. And it's to basically centre the conversation around these aspects. So what will active monitoring consist of in your hospital? How does that look like? Some people, some hospitals have remote monitoring. Some people have telephone services. there's various different things that can happen, but it's what matters to you, or how things work for you is really important in this stage. Also, the symptoms and knowing the symptoms is really important. I think there's still a lot of people that I speak to that have had WM for a number of years that may not fully know all of the symptoms, and they might be carrying on with their life, and or might haven't be having, it might be affecting their quality of life, but they don't mention it because they don't realise that, for instance, blurred vision can be related to their WM, and that can be a reason or trigger treatment to actually improve quality of life. And then also additional support and things like research and whether you can be involved in clinical trials that are coming, and then about lifestyle and what you can do to live well. So if you haven't seen this before, it's important that you do, and we can support that and give you these checklists. And I've been involved in one of the projects rolling this out and looking at how important it is for WM patients. So that is the end whistle stop tour. I'm going to stop sharing the screen now, and then we can move to questions.
Thank you so much, Chrissie. That was incredibly valuable and really informative. So yeah, it was great. Thank you very much. Has anyone got any questions that they'd like to ask Chrissie? I think a message has just come up in the chat box. So I'll have a look.
Can I ask a question, please, Christina?
Yeah, sure.
What is considered to be a high level of paraprotein?
It can really vary. So I've had people that have had paraproteins above 50, that have been very high. But equally, I've had people that have had a paraprotein of 20 plus, that are having quite significant symptoms. So it can really vary. And what I've always surprised about is that you would presume that if you had a really high paraprotein, you'd have all of these symptoms. But there are people out there that have a high paraprotein and don't have a lot of symptoms, which is unusual because it normally comes hand in hand. So often it's really about the symptoms as well as the paraprotein, but normally above 20. But it all depends on how stable the level is as well. I have got people that I look after currently that have got a high paraprotein, but it hasn't changed in the past 6 months to a year. It's like flatline, and that's not a concern for me. It's when it's going up and you're seeing the rise and people are getting symptoms that's the concern, rather than just the number.
Yeah. Okay. Thank you for that.
Is that all right?
Very informative presentation. I enjoyed that. Thank you.
Thank you.
So we do have quite a few comments that are coming up in the chat box now. The first one from Kamal. If it's okay with you, Kamal, what we can do is reach out to you after the webinar, if that's okay. So it does sound very complicated, bless you.
Sure.
So yeah, so I'll give you a call if that's okay. We can go through that one together.
Thank you.
There's a question from Julie, which says, why does a PET CT scan stop before the legs, especially with very painful peripheral neuropathy in legs?
Why does it stop?
Yeah, so why doesn't the scan go all the way down to the feet? Basically, it stops at the legs.
So it's based on the scanner. It gets the majority of the body in, the PET scanner. Now, the thing is the PET scan will cover all of the areas that the lymph nodes would be a problem in. So we don't often see issues of enlarged lymph nodes in the feet. So really, it's the main part of the body that we are interested in, and the legs to an extent are covered in that, but not the lower limbs. But I do get the point. It's not a full like a MRI, get my teeth back in. But it's not valuable in that sense. So it's not necessarily required. But I do get that.
Thank you. And then we've got a question from Leslie who says, why does low lymphocyte test, what does a low lymphocyte test mean, please?
So we know that lymphocytes specifically are a white cell that are needed to with infections, basically to help fight infections. We know that in certain lymphomas like WM and other lymphomas that the lymphocyte count is affected, and people can have a low lymphocyte count based on the overproduction of other cells, and that can affect their immune system. So sometimes people's lymphocytes count might be absolutely normal or look normal, but actually we know that these conditions are impacting the way that our immune system works. So sometimes it can be quite deceptive. If you just look at a blood test and somebody's white cell count looks normal, that doesn't necessarily mean that they wouldn't still be at risk of infection, because we know that the mechanism of how lymphoma and WM works is that it impacts the immune system in general.
Thank you very much. Helen has asked, is it dangerous to fly with high IgM but no symptoms?
It depends whether if you've got no symptoms at all, and you're not on treatment, then it should be fine and safe to fly. I would check that with your clinical team. Most of the time, people do travel. I think what we find an issue is if people have got high levels of paraprotein that are rising. And are rising exponentially. So if yours are high, but they're kind of staying the same and they're not changing much, that's stable. But if it's increasing, or you have these hyperviscosity symptoms, so the blood's really thick and you're starting to get things like headaches, and we know blood clots are, a bit more prevalent, those are more of an issue or a concern. So I would just check before booking a holiday. I'd just check that it's safe for you to fly. And yeah, it depends as well if you're having bleeding symptoms or if your platelets are affected. If your platelet level is low because it's affected by the WM, it might mean that it's a little bit more tricky to fly, just because the risk of having blood clots or kind of spontaneous bleeding is higher with that air pressure. But usually if you've got a really low platelet count, you're being treated for WM. It's one of the reasons that we would be treating if the WM was impacting your the production of your normal cells that much. So yeah, hopefully that helps. But I would check, but it shouldn't be the only reason that would stop you from flying.
That's great. Thanks, Chrissie. We've got a lovely comment from Sheena. It's not a question, but she says, thank you, even for an old-timer WMer, a very helpful explanation and excellent clarification of kappa and lambda proteins.
Lovely,
That's
thank
really
you. I
nice.
appreciate
Yeah,
that.
that's
Thank
lovely.
you.
And then Kamal says, does it really take a lot of months to be diagnosed with WM?
It can do, yeah. So often the difficulty is with lymphoma in general is that it can look like other conditions. And I think because WM is rare, it's a rare type of cancer, it's not often the first port of call of people's thinking when they go and see the GP. I think if your GP is experienced, and has seen cases of LPL or WM or lymphoma, it might be on their mind a bit more. But it depends on how you come through. I find that people that have symptoms, generally that the diagnosis process can be a bit quicker than someone that has no symptoms at all that have come through, is because they're almost hunting for a diagnosis, or that it comes, they're looking at alternative diagnosis. And what we know is with bone marrows, because we need a bone marrow to confirm a diagnosis, we can definitely suspect WM or suspect lymphoma, but to actually get the confirmation, you need to have completed the bone marrow biopsy, which can take time to get the report back. And the genetics can take a while, unfortunately. And that's the issue is, I can mostly say to people, we might be at some stage about 80% sure, but we need that or even 90, but we need that confirmation and the genetics part as well. It's like the whole picture, basically. It's not just one aspect.
Yeah, that's very helpful. Thank you. Now, Victoria has asked, what is the other time for a bone marrow apart from the time when the person was diagnosed?
So sometimes if there is a worry of progression, or they want to see how you're responding, it all depends because it's different depending on how you present. So if somebody has a lot of lymph nodes or enlarged lymph nodes, if they have a CT scan and they have treatment and they have a repeat CT scan and all those lymph nodes have gone down or gone completely, they would then not necessarily do a bone marrow if they've seen that improvement, because that's kind of given them the answer to say, well, you've had the CT scan, that's shown us that you're in remission, or we can't see any of the lymph nodes affecting. If you're somebody that was diagnosed and you don't have a lot of lymph nodes, or that's not really the big issue here, then a bone marrow can be helpful to kind of see where you're at, and it can be done to recheck progression of disease.
Excellent, thank you. Paul has said, excellent presentation, thanks. How do they test for genetic mutations? I've had blood tests, bone marrow biopsy, and a CT scan, but no one's mentioned genetic testing yet. Mind you, my diagnosis coincided with the big fire at Southampton General Hospital, so it's been a bit chaotic. Oh dear.
Oh,
Gosh.
okay. Yeah, that was a bad fire that they had.
Absolutely.
So
Yeah.
the genetic testing is done via the bone marrow. So when they do the bone marrow, they send it away to look at all different things. So they look under the microscope. So your hematologist consultant would, as soon as they get the liquid part, they put it on a slide, and they put some staining on it, and then they'll look under the microscope and they can see certain cells and what the cells look like. And what you're looking at really is, do the cells look abnormal? There is a way that the cell should look, and you can kind of detect if there's something not right with the bone marrow. So, for instance, if there should be a certain amount of red blood cells, or you should see a pattern, if they are sparse and you can't see any, or there's very few, you might go, okay, there's something here, or there's a lot of lymphocytes on this, or there's a lot of these B cells. You kind of tell from that aspect, but then it needs further testing. So when the trephine, which is the bony part, when that gets sent away, that's often tested for the genes and the mutations. So it might be that you've had all of these genetic testings, but you just don't know what the result is. And sometimes the genetic testing can be more academic, that it might not be necessarily, which sounds a bit weird to say, but it might not be that relevant to you. It might be more academic, but it's good to know, I think. But like we say, for the majority of people, you would have the mid 88. That's the gene that's often affected, and that's what kind of diagnoses it. So a lot of people get a diagnosis because they've got this mid 88.
Okay, and High Tendra has asked how you can measure immunity.
That's a really difficult one, actually,
Yeah.
because there's a lot of things that people can do. So sometimes people can do things like a CD4 count, which kind of says how our immune system is responding. But what we're looking at in general is the immunoglobulins, and the total immunoglobulin level, and how in range that is. We know for certain lymphomas, if the levels are a lot lower, it might be that you're more at risk of infections. But it is difficult almost to say how at risk people might be, or we're not at the point of saying or being able to classify risk so specific to that person. But we can see there's been a lot of questions around vaccinations in the past, and about whether you can test whether vaccines have worked via CD4 counts and things like that. But the difficulty is often is you can find out that maybe your response to certain things aren't as good. But the difficulty is there's nothing in place at the moment that would allow you to have more of that. So for instance, if you had your COVID spring booster and I was able to test your antibodies to COVID, if your antibodies came back and it showed that you didn't really make many, I can't give you another COVID vaccine. There isn't anything at the moment that says that you could have, if you've already had the vaccine, the current one, I couldn't revaccinate you for it, even if you didn't have that good of a a good of a response to it. So sometimes what's difficult is you can find out certain things of how people respond to certain things or what level of immunity they have. But the difficulty is what do you do with that information? As in, yes, that could help us say, oh, maybe we should be a bit more careful, but we can't actually give you another vaccine. Does that make sense? But I know that it's wanting to know, and I do get that.
Yes, definitely. Rosamond has said, I never had B symptoms, but no matter what treatment I have had, my paraprotein only ever goes down to 4, then starts rising again. By the time
Yeah.
it reaches high 20s, I need treatment again. I have very bulky disease. Can that be the reason I never have full remission?
Potentially, and we do see for some people that treatment can be really effective in getting their paraprotein down, and then the paraprotein will start to come up again. And sometimes you can see it that it we know that it's going to maybe we know that it's going to come back up, but sometimes it might slow the rate of progression down between treatments, or other people they can just be unfortunately unfortunate that their disease is quite progressive, and it comes back quite quickly. And sometimes it's then longer term treatments that are available now that are more continuous, things like zanubrutinib that have been licensed, that you might need to be on a treatment just to kind of take it. But it's very difficult with WM in the sense that if you don't have symptoms of it, there is an argument of when's the right time to start treatment. Because actually, if it's not doing any harm, which sounds a weird thing to say, because cancer cells are cancer cells, but if it's not doing your body harm at that point, you don't want to give you a treatment that could impact your quality of life if actually your quality of life was okay to begin with. So it is that balance, but it probably is the bulkiness or the acuity of your disease. It might be that you've got these mutations and they are just a bit more rampant, unfortunately.
Thank you. Claire has said, is there anything I can do to help my IG levels improve? So thinking that's just your IgM or your immunoglobulins in general.
There's nothing really that you can do, particularly to help that. No, unfortunately, there's nothing personally that you could do. It's just unfortunately part of this process. Sometimes there has been links with other conditions where they can give immunoglobulin infusions, but normally with WM you don't really see that as much. It's mainly with things like CLL that you see that, because actually normally you've got more of an overproduction rather than an underproduction of these cells. So it's more that you've got too much rather than too less, not enough, if that makes sense.
Yes, absolutely. And then someone called Kay McLennan, they have put a message saying my anti-MAG antibodies were unaffected by chemo, but the paraproteins were reduced. I have peripheral neuropathy. How do they monitor my neuropathy if the anti-MAG antibody test just came back high with no actual value?
That's a challenge. It's very tricky. Of how you would monitor that, especially if your anti-MAG levels didn't come down. I guess the question is did your neuropathy, did the neuropathy improve when the paraprotein came down or not? Or did it not at all?
No, it didn't make any difference at
It
all
didn't
to
make
my
any
group.
difference.
No difference at all.
Mm, mm. That is challenging because it might be that the thing is with peripheral neuropathy often in these scenarios is it may not get better and it might just stay that way regardless of treatment, unless they can target it. But if it's not related to the paraprotein and it's this anti-mag, but the treatment hasn't reduced that, it's one of those symptoms that this is not helpful for you clearly, but that it almost they have to keep an eye out or monitor, but that treatment might not necessarily help. Hopefully in the future with other treatments that become available, it will help in with that. Are they thinking about giving you more treatment, or are they waiting for the paraprotein or your symptoms to worsen?
Basically, they're saying that they're going to do nerve conduction tests regularly
Right.
to monitor the peripheral neuropathy, and kind of will take it from there. But it
Yeah.
doesn't sound particularly good when, I know that the chemo has worked to a certain extent, but it obviously had no effect on the antibodies. But I find it very frustrating that they just come back and say the level is high. But high as anything is over 70,000. That could be 170,000 or it could be 80,000. I've got no idea what high means, unfortunately.
Mm. Yeah, that is tricky. I'm sorry about that. Yeah, I think nerve conduction studies are helpful. Regular ones are helpful. But obviously it's tricky because it wouldn't, these things aren't going to get better unless unless the treatment is effective for it. So nerve conduction often then shows if there's any other reasons or other causes that causes a neuropathy, and whether they can sometimes they can detect other things that are causing it and help that way. But I know because I've got quite a lot of patients that really struggle with peripheral neuropathy and the anti-mag, and it's one of those that it is challenging, and it's trying to learn to live with that, which I know is easier said than done. So I do appreciate that's difficult.
Thank you,
Thank
Chrissie.
you.
Hi, Tendra has asked another question. What should your white blood cells be? What should your counts be?
What's the normal white cell count? Or
Yes, I believe so. Yes, what should your normal white count be?
so it can vary between about 4 and 10. The different hospitals have different remits, depending on their scanners or their testing systems. So our one is about between 4 and 10 or 4 and 11. It is the normal range. And then obviously if it goes above 12, then it's slightly raised. But the thing is with infection or inflammation, you can see a raised white cell count. It's when it's going to double figures that's a bit more or higher than 20 is more of a concern. And then obviously you can see low total white cell count, normally with treatment or as well. You can see that if infection's a bit more present, that people can have a low white cell count too.
Okay. And then Keith has asked a question. He says, I am 8 years in on active monitoring and 6 monthly checkups. I have currently found enlarged glands in the neck with neuralgia going from right-hand side of face. Oh, sorry about that, Keith. Is this a cause for concern?
So then, sorry, they're new lymph nodes that have come up.
It says I have currently found enlarged glands. Keith, are you able to just to let us know if they're new nodes or if it's something that you've had long-standing at all?
Sorry, it's been with me 3 weeks.
3 weeks.
3 weeks.
And have you had any other infection type symptoms in the last 3 weeks?
I've got dermatitis in my head, which has been with me for 4 years.
Okay.
This neuralgia goes through to my eye, you can feel it.
Okay, and that's new.
Yeah.
Okay, so yeah, I would say if you've got new symptoms like that, especially when it's affecting the feel of your face, then it's important to get that checked out. So I would, if I was you, I'd contact your clinical team and ask for your appointment to be brought forward. And they should really see you face to face and do some blood tests as well, just to check what the levels are. Sometimes we know that lymph nodes can come up and down with infection. So sometimes if you've had a recent vaccination, you've had coughs, cold, toothache, earache, anything like that, it can cause these lymph nodes to come up in the neck. But if it's persistent and you're starting to get what you're describing, I think it's worth getting checked out, Keith, definitely.
Right, thank you.
Okay, so we still have quite a few questions actually. Amazingly, we've got at least a further 22 questions, which is
Oh, wow.
great. A lot actually. We will be finishing at 7, but I just wanted to say that if there's questions that we can't get through to, which at this rate will be quite a few, unfortunately, we'll definitely get back to you with a response. We just won't be able to answer them this evening more than anything else. So moving on to Steve's question. He says, is there a way you can see your blood results? Typically, I've had to wait 8 to 10 weeks for consultant letters, and the detail is not consistent letter to letter. As it's from different consultants, sorry. I am moving to a CNS referral, so 6 monthly bloods. Just wondering if that is more timely in the NHS app or visible in the NHS app.
Yeah, so I mean, it is variable, so it all depends on how your hospital works. So for us personally, we have to select a specific button each time a blood test is requested. We have to tick that it goes to the GP in order for it to be uploaded onto the NHS app. It doesn't automatically go onto the NHS app, believe it or not. So if you really want a copy of your blood test results, it's important during your consultation to say to them at the time that you want that blood request to pull through to your GP so it can go onto the NHS app. Because the thing is it's not one of those systems that it would be helpful if it was all opt-in and then you have to opt out. But you have to ask, and sometimes, unfortunately, the consultant, when they're requesting it, they may just forget to click the button that's needed. If you do want to have copies of your blood test results, and it's not as easy as it just going up on the NHS app, as I've said, then you can contact the haematology secretaries normally. The admin team normally should have an email address in your hospital that you can email in, or even your specialist nurses, and ask for a copy of your blood test results. I often have a few people that will ask me because it doesn't go through to the NHS app on their system, and they ask me if I can send them the results. So it shouldn't take that length of time at all. So yeah, I would, if you are keen to have a copy of your blood test results, they are yours. So if you want them, then just ask. But I would ask at that appointment, especially for the next time. And if you wanted a copy, that they can always send it out with the letter, or send it out separately to the letter so it comes sooner.
Thanks, Chrissie. And probably just the last question for this evening, but a very interesting question. This is from Claire. She says, I had a lymph node biopsy rather than a bone marrow to confirm the diagnosis. How did they manage that?
Yeah, so it might be if you had really bulky lymph nodes, they can do gene testing on that too. Yeah, so sometimes if people have got bulky lymph nodes and they were investigating, because the thing is if you presented, and obviously I don't know in your case, but if you presented originally with bulky lymph nodes, they would be looking at what type of lymphoma this is. So they would suspect lymphoma, but unfortunately there's over 50 types of lymphoma. So it could be various things. So they're looking at what that could be, and typically, often from a lymph node, WM is not the first one that you'd go for, actually, if you were to put a bet on it. So it might be that obviously when they when they took that lymph node and they looked under the microscope and they saw the presence and seen antibody, IgM, or they detected that, and then they can then send that off for genetic testing further. So it's probably that they did it that way for you because that showed on the lymph node. So yeah, it can be done that way as well, and that would have saved you a bone marrow biopsy because they didn't need to do that.
They were looking for WM when they did the lymph node biopsy.
Yeah, they were probably looking for all the different types of lymphoma at the time, but they might have suspected it from your bloods then.
Maybe.
Yeah. But that's good that you didn't have to have a bone marrow.
I had to have it afterwards.
Oh, sorry. Okay.
Nearly got
Sorry
away
about
with
that.
it.
Boom. That's mean.
Oh, well, thank you so much, all of you, for joining. And thanks again to Chrissie for presenting such a clear and informative session. You were wonderful. And even myself as a nurse found it incredibly helpful and valuable. So yeah, we can't thank you enough.
Oh,
And
great.
as I said before, all the questions that we haven't got round to answering, myself and some of my colleagues will be answering your questions as best as we can over the next few days. So we'll definitely get in touch with each of you. So yeah,
Oh, thanks everyone. It was great to spend the evening with you, and I hope you have some dinner if you haven't had it already. Yeah, be in touch.
Yes, thank you very much indeed.
See you later. Bye everyone.
Bye.
Bye.
Bye Rachel. See you later. Thank you.
Bye. See you, Chrissie. Thank you.